Welcome to the Radon Smart Review GU Cancer series.
It is great to be here for this one.
Yeah, today we are tackling episode 30, Penile Cancer Primary Management, Nodes, and Organ Preservation. And imagine sitting in an exam room, right? You are looking at a patient who noticed a lesion on his anatomy over half a year ago.
Yeah, but because of intense psychological stigma or just sheer fear, he stayed away from the doctor.
Exactly. And now he is sitting in front of you. You are examining the visible local destruction, but the real threat is completely invisible to the naked eye.
Right, because his survival right now hinges entirely on this microscopic crossing highway of lymphatic fluid silently draining into his groins.
You are not just managing a primary tumor, you are racing against a fiercely methodical metastatic pathway.
That is the perfect way to phrase it. Penile squamous cell carcinoma is incredibly rare in the developed world, but it is a total crucible for clinical decision-making.
It really is. And because of its rarity, and because it forces you to synthesize strict anatomical logic with these profound quality of life trade-offs, it is heavily scrutinized on oral boards.
Yeah, I mean, if you just try to memorize a flowchart for penile cancer, you will fail.
Totally. The guidelines from the NCCN or the EAU and ASCO, they often differ slightly in their philosophies.
Right, you actually have to understand the fluid dynamics of the lymphatic spread and the physical limits of our treatments.
And since most of us will only manage a handful of these cases during training, you have to build a rock-solid mental framework today. So our mission is to master 3 core concepts.
First, understanding why inguinal nodal status is the absolute driver of survival.
Second, navigating the CN0 groin, specifically that critical biological split between T1A and T1B disease.
And third, knowing the exact indications and the incredibly nuanced patient counseling for organ-preserving radiation therapy.
Yes. And to keep this grounded, you need a case anchor. So put yourself in the clinic room with this patient. He is a 62-year-old uncircumcised man.
Okay, classic demographic.
He has a 40-pack-year smoking history and a decades-long history of severe phimosis.
Meaning he has been basically unable to retract his foreskin.
Right. And he presents, after that 6-month delay, with a persistent, foul-smelling 2.5-centimeter ulcerative lesion right on the glans penis.
So the urologist performs a dorsal slit, just a surgical incision along the upper part of the foreskin, to fully visualize the lesion.
And they take a punch biopsy.
Yep. The pathology returns as a moderately differentiated squamous cell carcinoma, grade 2. It shows invasion through the subepithelial connective tissue, which is the lamina propria.
Okay, and what about the specific features?
Well, lymphobascular invasion, or LVI, is positive. Perineural invasion, PNI, is negative. And importantly, his P16 is positive.
So that gives us the tissue diagnosis, but to figure out the local and regional risk, you need his clinical staging.
Right, the physical exam is key here.
So on your exam, you palpate a single mobile 1.5-centimeter lymph node in his right groin. The left groin feels completely soft and normal.
And the imaging.
You order a CT of the chest, abdomen, and pelvis. That shows no enlarged pelvic nodes and no distant visceral metastases.
Good.
You also get an MRI of the penis, which shows the tumor involves the lamina propria and extends into the superficial corpus spongiosum, but it clearly stops before the corpus cavernosa.
Okay, so the surgical team calls you. They want to know, can we offer this man organ-preserving radiation therapy, and what exactly is the algorithm for his groins?
But before we start throwing around radiation doses, we need to dissect the disease itself, because over 95% of these malignancies are squamous cell carcinomas.
Yeah, but treating squamous cell carcinoma as one monolith is just a massive oversimplification.
It really is, isn't it?
Totally. There's a deep, fundamental histological divide. You are dealing with 2 entirely distinct biological pathways that just happen to look similar at the end.
Break that down for us.
First, you have the HPV-associated pathway. These tumors classically present with basaloid or warty histological patterns.
And they are driven by HPV-16 mostly.
Right. Mechanistically, the viral oncoproteins E6 and E7 hijack the host cell. E6 degrades P53, the genome's guardian stopping apoptosis.
And E7 binds and inactivates the retinoblastoma protein, RB, right?
Exactly. RB normally halts the cell cycle, so when RB is knocked out by the virus, the cell dramatically upregulates the protein P16 in this desperate, failed attempt to stop cell division.
That is so fascinating. That is why P16 is our surrogate marker for HPV infection.
Yep, which perfectly aligns with our 62-year-old patient, whose tumor is P16 positive.
But what about the other half of patients, the ones without HPV?
That is the HPV-independent pathway, driven purely by chronic, localized inflammation and environmental damage.
Like the usual type or verrucous squamous cell carcinomas.
Exactly. The risk factors here are highly mechanical and chemical. Phimosis is a massive driver.
Because when you have chronic phimosis and you lack neonatal circumcision, smegma gets trapped, right?
Yes, smegma, desquamated epithelial cells, and moisture gets trapped under the foreskin. This creates a chronic inflammatory microenvironment.
It's constant oxidative stress over decades.
Right, reactive oxygen species causing direct DNA damage. You also see conditions like lichen sclerosus acting as a precursor.
And then, bridging both of these pathways, you have smoking.
Yeah, smoking introduces systemic carcinogens that concentrate in bodily secretions. It is a profound cofactor that accelerates either the viral or the inflammatory pathway.
Okay, let me push back on something regarding the P16 status.
Mm-hmm.
In head and neck cancer, like oropharyngeal SCC, we know that HPV-driven tumors are incredibly radiosensitive.
Oh, absolutely.
So much so that we literally have a separate staging system for them, and we run trials to de-escalate their radiation dose. Our patient here is P16 positive. Can we back off our aggressiveness because he has the quote-unquote better biology?
I mean, that is a highly logical assumption based on head and neck data.
Yeah.
But in penile cancer, it is a dangerous trap.
Really, no de-escalation at all.
No. While retrospective data strongly suggests that P16 positivity confers a better disease-specific survival, they do respond better to systemic therapies and radiation. It does absolutely nothing to change the established local treatment algorithm right now.
Wow, okay.
You do not de-escalate treatment off protocol. You cannot ignore a positive node just because the primary is P16 positive. The anatomical rules remain strictly enforced.
Which forces us to look at the anatomy. Let's talk about the biological mechanism of how this cancer spreads. We always hear that the lymphatic drainage is predictable. What makes it so predictable?
It is fiercely methodical because of the underlying vascular and lymphatic architecture of the pelvis. The fluid from the prepuce and the glands drains almost exclusively into the superficial inguinal lymph nodes first.
And those nodes sit right there in the subcutaneous tissue of the groin above the fascia lata.
Right. From those superficial nodes, the efferent vessels pierce the fascia lata to drain into the deep inguinal nodes, which are clustered around the femoral vein.
And then it goes deeper.
Yes. Only after traversing that deep inguinal bed does the fluid travel under the inguinal ligament into the pelvic nodes.
I want to break down the fluid dynamics here because the mechanics make the clinical rules obvious. I think of it like a sequential security checkpoint system.
Oh, that is a great analogy.
Thanks. So the superficial inguinal nodes are the front door metal detectors. The deep inguinal nodes are the secondary bag check. And the pelvic nodes are the secure terminal.
That tracks perfectly.
If a tumor breaks off from the glands, it physically cannot bypass the front door metal detectors to reach the pelvis. It gets trapped. But once that first detector is breached, the rest of the facility is under threat.
And here is the most critical mechanical feature of this system. The lymphatic vessels at the base of the penis freely anastomose.
Meaning they cross the midline?
Exactly. The fluid from a tumor sitting entirely on the right side of the glands can easily shunt across the base and drain into the left superficial inguinal nodes.
Because of this crossflow, bilateral groin risk is just inherently built into the disease. You can never assume a unilateral tumor means a unilateral risk.
Never.
And this brings us to the ultimate clinical reality of penile cancer. If you take away one absolute truth about this disease, what is it?
The single most important prognostic variable is nodal status. The groins completely drive survival.
Period.
You can do a masterful job curing the primary tumor on the penis, but if you mismanage microscopic disease in the groins, they'll develop regional failure, pelvic invasion, and death. You have to get the staging right.
So if the groins dictate survival, we need to accurately stage the local tumor to assess that risk. Let's decode the AJCC 8th edition staging. And I want to get granular here.
Yeah, let's go layer by layer.
We start with TIS, carcinoma in situ, then TE, non-invasive verrucous carcinoma. But the real decision tree starts at T1.
Where T1 means the tumor is broken through the epithelium and invaded the subepithelial connective tissue, the lamina propria.
But the guidelines aggressively split T1 into T1A and T1B.
Because lamina propria invasion is heterogeneous. T1A means it invaded the lamina propria, but it lacks high-risk features. It is well or moderately differentiated, and it does not have LVI or PNI.
So it is relatively lazy.
Yes. T1B, however, means it is either poorly differentiated grade 3 or it has positive LVI or PNI.
And the presence of LBI means the tumor cells have physically chewed their way into the endothelial lining of those microscopic lymphatic channels?
Exactly. It is a direct mechanical indicator that tumor emboli are likely already in transit to the groins.
Okay, so T1 is lamina appropriate. To remember the deeper structures, I use the simple mnemonic based on the layers.
Let's hear it.
T1 is one layer down the lamina propria. T2 is the second layer, the spongiosum. T3 is the core, the cavernosa.
That maps perfectly to the anatomy. T2 indicates invasion into the highly vascular erectile tissue surrounding the urethra. T3 is invasion into the deeper, tougher corpora cavernosa.
And T4.
T4 is invasion into adjacent structures like the scrotum, the pubic symphysis, or the prostate.
Okay, let's bring this back to our 62-year-old case anchor. We have a conflict in our workup.
We do.
The punch biopsy showed lamina propria invasion with positive LVI. Based on the biopsy alone, that is a T1B. But the MRI showed tumor extending into the superficial corpus spongiosum.
This is a massive debate in tumor boards.
Does an MRI actually override a direct tissue biopsy and physical exam? I mean, I've seen MRIs grossly overcall the depth of invasion because of peritumoral edema.
Oh, right.
Inflammation looks bright on T2-weighted imaging, and the radiologist calls it cavernosal invasion when it's really just fluid. Should we really upstage this patient from a T1 to a T2 based on the scan?
You are hitting on a vital clinical nuance. You are right that MRI can overstage, which is why a rigorous tactile physical exam by your urologist is irreplaceable.
You have to physically feel the induration.
Yes. However, a punch biopsy has mechanical limitation. It is a tiny, localized core. It frequently undersamples the deepest part of the tumor.
That makes sense.
When you are considering organ preservation, you need a macroscopic view. High-resolution MRI with an artificial erection is the best non-invasive tool we have to evaluate the corpora cavernosa.
So how do we stage him?
In clinical practice, if the MRI definitively shows spongiosum invasion and the clinical exam is consistent with a deeper lesion, you respect the MRI findings. We stage him based on the deepest known extent.
Following our mnemonic T2 is the second layer, the spongiosum. He is clinically a CT2. Now let's stage his lymph nodes.
Okay.
He has a single, palpable, mobile 1.5 centimeter node in the right groin. Clinically, CN0 means no palpable nodes. CN1 is a single, palpable, mobile unilateral node.
Which is exactly what he has.
Right. And just to finish the thought, CN2 is multiple or bilateral mobile nodes, and CN3 is a fixed inguinal mass or any pelvic adenopathy.
Because he has that one mobile node, he is definitively CN1. And his CT scans are clean, making him M0. So his stage is CT2, CN1, M0.
Because our patient is CN1, the way we handle his groins is going to be completely different from a patient whose exam is negative.
Day and night difference.
I want to split the groin rules into two distinct pathways. The CN0 groin and the CN positive groin. Do not mix these up.
Let's start with the CN0 patient. This is the guy where both groins feel completely soft.
No lumps, no induration. Why can't we just tell this guy he's clear and send him home?
Because the physical exam is profoundly insensitive for microscopic metastatic deposits. Even when they feel perfectly normal, about 20 to 25% of these men already harbor occult cancer cells in those nodes.
1 in 4. That is terrifying.
It is.
If 1 in 4 has cancer in their normal groins, how do we ethically decide who gets safely observed and who gets an invasive surgical staging procedure?
The threshold is entirely dictated by the primary T stage. If the primary tumor is TIS, TA, or low-risk T1A, the statistical probability of occult disease drops to around 5 to 10%.
And at that low probability, the morbidity of groin surgery outweighs the oncologic benefit.
Exactly. So for T1A, surveillance is the standard of care. You observe them with rigorous exams and ultrasounds.
But the moment that primary tumor shows aggressive features, like T1B, T2, or T3, what happens?
The risk of micrometastatic disease surges past 20%. Observation is oncologically dangerous. Invasive nodal staging is heavily recommended by all major guidelines.
And what are the actual mechanical options for that? Are we doing a massive modified inguinal lymph node dissection on everyone?
No, thankfully. The preferred modern approach at high-volume centers is a dynamic sentinel node biopsy, or DSNB.
Talk us through that.
We inject a radioactive tracer, usually technetium-99 meters, and a blue dye directly around the primary tumor.
So right on the penis.
Right. We let the lymphatic fluid carry those tracers naturally. Then the surgeon uses a gamma probe to find the very first lymph nodes that light up and turn blue. Those are the sentinel nodes.
The first physical filters.
Yes. If you remove just those 1 or 2 nodes and the pathologist says they are clear, you can assume the rest of the basin is clear, sparing him a massive dissection.
Okay, I want to use this mechanism to ask you a deliberate trap question regarding our 62-year-old anchor case.
Oh boy, let's hear it.
He is a CT2, but unlike the CN0 patients we just discussed, he has a palpable, mobile 1.5 centimeter node in his right groin. He is CN1.
Yes.
Since it is only one slightly enlarged node, wouldn't a dynamic sentinel node biopsy be the most elegant, minimally invasive way to figure out if that node is cancer or just reactive inflammation?
Absolutely not.
Not at all.
Suggesting a DSNB for a palpable node is an immediate catastrophic failure on your oral boards and in the clinic. DSNB is strictly, entirely, 100% a tool for the CN0 pathway.
Explain the physics of why it fails.
Think about the fluid dynamics. If a node is enlarged because it is completely replaced by squamous cell carcinoma, the architecture is destroyed. The afferent lymphatic vessels leading into that node become mechanically blocked by tumor emboli.
So the plumbing is just shut down.
Yes. When you eject the tracer into the penis, the fluid hits that blockage. It cannot enter the cancerous node. Instead, the pressure forces the tracer to reroute through collateral channels to a completely different, perfectly healthy lymph node nearby.
Oh,
Your gamma probe will lead you to the healthy node, you biopsy it, it comes back negative, and you falsely tell the patient he is cancer-free while a massive tumor continues to grow right next to it.
that is a phenomenal explanation. The blockage causes a false negative by rerouting the fluid. So for our patient, DSMB is completely off the table.
Completely. He is in the CN-positive pathway.
So what is the correct guideline-based approach for his palpable node?
When a patient is CN-positive, the goal shifts from finding microscopic disease to managing gross disease.
Right.
If you look at the EAU and ASCO guidelines, they advocate for an image-guided percutaneous biopsy of that palpable node before initiating major surgery.
Why do they want a biopsy first?
Because a palpable node in a patient with a highly inflamed penile lesion could easily just be reactive lymphadenitis. They want histological proof of cancer before committing a patient to a highly morbid bilateral groin dissection.
But the American guidelines don't entirely agree with that sequence, do they? The NCCN offers a different lane.
They do. The NCCN pathways are heavily influenced by a desire to avoid any delay in definitive treatment.
So they just go straight to surgery.
Essentially, yes. For a high-risk primary like RCT2 and a highly suspicious palpable node, the NCCN allows you to proceed directly to an upfront inguinal lymph node dissection, an ILND, without waiting for a biopsy.
Because the pretest probability is so high.
Exactly, and the risk of the cancer escaping while you wait is severe. So, on a board exam, you have to acknowledge this nuance. You state that EAU supports a biopsy, while NCCN permits upfront ILND. State both, then pick a lane based on clinical suspicion.
Let's play out the surgical management. Let's say we confirm the right node is positive. What is the standard surgical procedure? Is the urologist just taking out that one right node?
No. The standard of care is a radical bilateral inguinal lymph node dissection.
Wait, bilateral. Even if his left groin feels totally normal and the imaging is clean?
Yes. We go back to the anatomy we discussed at the very beginning. The lymphatics freely cross the midline. The rate of occult microscopic contralateral disease is just too high to ignore. If you leave the left groin alone, the risk of a catastrophic failure on that side is unacceptable.
That makes perfect sense mechanically. Now let's escalate the scenario. What if that node wasn't a small 1.5 centimeter bump? What if he came in with a 5 centimeter rock-hard mass fixed to the skin and the femoral vessels, clinically CN3?
That changes the paradigm completely. You cannot do upfront surgery there. You will leave gross tumor behind on the vessels.
So you must introduce neoadjuvant chemotherapy.
Yes, the preferred regimen is TIPI, paclitaxel, ifosfonid, and cisplatin.
Walk us through why TIP is the standard. How do these drugs actually work synergistically?
They attack rapidly dividing cells through 3 distinct mechanisms. Paclitaxel is a taxane. It stabilizes microtubules, paralyzing the cell's internal skeleton so it cannot pull its chromosomes apart.
And isosfamide.
It is an alkylating agent. It adds bulky alkyl groups to the DNA, causing catastrophic strand breaks.
And cisplatin cross-links the DNA double helix.
Exactly, preventing the replication machinery from reading the genetic code. The landmark Phase 2 study by Pagliaro showed that neoadjuvant TIPI produces an objective response rate of roughly 50% in these bulky patients.
So half the time, this cocktail melts the tumor down enough to untether it from the vessels, and then you can take them to surgery.
Right.
But what about the pelvis? When do we start worrying about the pelvic nodes and bringing in adjuvant radiation?
Pelvic concern is driven by the final pathology from the groin dissection. You are looking for high-risk features that suggest the tumor overwhelmed the inguinal filters.
Like multiple positive nodes or extranodal extension.
Yes, extranodal extension, or ENE, is when the cancer cells have grown entirely through the tough, fibrous capsule of the lymph node and are invading the surrounding fat. It is a harbinger of aggressive disease.
So when the pathologist sees ENE or multiple nodes, it triggers a mandatory multidisciplinary discussion.
Absolutely. The risk of pelvic node involvement is extremely high. You are looking at a pelvic lymph node dissection and heavily considering adjuvant radiation to the groins and pelvis.
So we have the entire nodal pathway mapped out, but we still have a 2.5 centimeter ulcerated tumor sitting on the patient's glands. Can we avoid a penectomy? Let's transition to primary management and organ preservation.
Historically, surgery has been the absolute bedrock of local control. A glandsectomy or a partial penectomy provides excellent, definitive oncologic control.
But the human cost is massive.
The psychological devastation, the loss of sexual function, having to sit to void, these are severe, life-altering consequences.
Which is exactly why organ-preserving radiation therapy, using either brachytherapy or EBRT, is a guideline-supported option. But it is only for very carefully selected early-stage tumors. You can't radiate a massive T3 tumor.
Right. We generally rely on the 4-centimeter rule.
Oh.
Organ preservation is reserved for lesions under 4 centimeters in maximum diameter.
And no cavernosal invasion. Explain the physics and biology behind that 4-centimeter rule. Why does radiation fail when a tumor gets larger than a golf ball?
It comes down to tumor hypoxia and dose distribution. As these tumors grow, they outstrip their blood supply. The center becomes necrotic and severely hypoxic.
And radiation needs oxygen to work well, right?
Exactly. Radiation uses oxygen-free radicals to make the DNA breaks permanent. If the tumor is starved of oxygen, it is fundamentally radioresistant.
Plus, if you are using brachytherapy, the dose falls off super fast.
Yeah, the inverse square law. It is physically impossible to deliver a curative dose to a bulky volume without causing catastrophic necrosis to the healthy penile shaft right next to it.
Let's check our 62-year-old anchor case against those rules. He has a 2.5 centimeter lesion. That passes the 4-centimeter rule. The MRI confirms superficial corpus spongiosum invasion, but no cavernosal invasion.
So he's technically a highly viable candidate for organ preservation.
But the art of oncology is in the counseling. How do you explain these trade-offs to a terrified 62-year-old?
I am brutally honest. I tell them, the trade-off is not about cure versus no cure. Both surgery and radiation are curative. The trade-off is anatomical. Radiation gives you a high chance of keeping your anatomy intact up front, but it carries a slightly higher risk that the local tumor might grow back.
And surgery gives you the highest guarantee the local tumor will never return, but requires amputation.
Precisely.
And what happens if the radiation fails? That is always the next question. Am I going to die if the cancer comes back?
No, and that is a crucial point. If the radiation fails locally, salvage surgery, a delayed penectomy, is usually highly effective and still curative, so you're giving them a chance at preservation with surgery as a backup.
What are the success rates for keeping the organ with brachytherapy?
For properly selected small T1 and T2 tumors, local control and preservation rates are commonly 70 to 80% at 5 years.
7 or 8 out of 10 men get to keep a functional organ? That is amazing.
It really is.
While we are discussing evidence, we must talk about the IMPACT-T trial. Massive trials are rare here, but IMPACT-T is trying to change that. Can you break down the architecture of this trial?
The IMPACT-T trial is the most important active phase 3 trial in penile cancer right now. First, the accrual goal is 200 patients, not 400 like some old literature says.
And it is for clinically node-positive disease, right?
Yes, and it uses a highly complex design with 2 sequential randomizations to answer both the upfront groin question and the subsequent pelvic question.
Sequential randomizations can be tough to visualize. What is the very first randomization?
The first randomization addresses neoadjuvant sequencing. A node-positive patient is randomized to either upfront radical ILND or neoadjuvant chemotherapy followed by surgery, or neoadjuvant chemoradiation followed by surgery.
That answers if shrinking the disease before surgery improves survival, and the second randomization.
If the final pathology from the groin surgery shows high-risk features like extranodal extension, the patient is randomized again, this time to prophylactic pelvic lymph node dissection versus observation.
It is an incredibly elegant design.
It perfectly mirrors the dilemmas we face in tumor board.
Okay, returning to our patient. Let's say he hears the 80% success rate and chooses radiation. He refuses surgery. Executing penile radiation is fraught with bizarre physical challenges. What is the absolute non-negotiable surgical prerequisite before we even simulate him?
Circumcision. A therapeutic circumcision must precede penile radiation. Non-negotiable.
Why is it an absolute must? What is the physiology there?
The foreskin is highly sensitive and prone to immense fluid shifts. If you apply 60 to 70 gray of radiation to an uncircumcised penis, the radiation destroys the microscopic capillaries in the skin.
So you get massive fluid extravasation.
Yes, severe radiation balanitis. The foreskin will swell with edema to the point that it traps the glands underneath.
Creating a tight, moist, necrotic chamber.
Exactly. Infection risk skyrockets, pain is excruciating, and crucially, you cannot retract the foreskin to visually evaluate if the tumor is shrinking.
So it must be removed and fully healed before radiation starts. Okay, he is healed and comes in for external beam radiation simulation. We are dealing with a highly mobile target. How do you reproduce the setup every day for 5 weeks?
It is the hardest technical challenge of EBRT here. We usually use a supine frog-leg position. The legs are splayed outward.
And you have to stabilize the penis.
Yeah. Frequently using custom-made thermoplastic molds or wax blocks, you have to immobilize it in a specific orientation, especially if you are matching the primary target to lower-dose prophylactic groin fields.
And we also have to manipulate the physics of the radiation beam itself.
Yeah.
Squamous cell carcinoma of the glands is a surface target, but high-energy photons penetrate deeply, right? They don't deposit their max dose on the skin surface.
Right. The dose builds up a few centimeters below the skin. So if we just point a bare beam at the penis, we will severely underdose the actual cancer on the surface.
So how do we force the dose to the skin?
The use of bolus is absolutely essential. Bolus is a tissue-equivalent material like a custom wax block, a water bath, or synthetic gel that completely encases the penis.
So the photon beam hits the bolus first.
Exactly. The Compton scattering interactions begin inside the bolus, so that by the time the beam physically reaches the patient's skin, it has achieved DVAX.
Without bolus, you get a gross local failure. What about the urethra? It runs right through our target volume.
During the simulation CT scan, a small Foley catheter can be placed into the urethra. It acts as a highly visible fiducial marker, so the radiation oncologist can contour it slice by slice.
And what are the curative doses we are aiming for?
For definitive treatment of the primary lesion with EBRT, 65 to 70 gray over 6 to 7 weeks. For the prophylactic groins, 45 to 50.4 gray.
What is the acute biological cost of 70 gray to the genital epithelium?
The acute toxicity is severe. You must prepare them for brisk, painful skin and mucosal reactions. The radiation sterilizes the basal stem cells, so the skin cannot replenish itself.
They develop confluent moist desquamation, right?
Yes, the skin essentially peels off, leaving weeping, exposed dermis. They will experience intense dysuria and need daily supportive care, like opiate pain control, sitz baths, and barrier creams.
And if you radiate the groins, the inguinal fold also suffer this moist peeling, but that acute toxicity eventually heals. What is the permanent late toxicity you must disclose upfront?
The late toxicity that oral board examiners absolutely require is urethral or meatal stenosis. The radiation causes chronic microvascular damage, leading to progressive fibrosis and scarring over years.
Creating a stricture.
Yes. They develop a weak urinary stream and may require repeated urologic dilations or reconstructive surgery later in life.
Any other risks?
Soft tissue necrosis of the glands happens at about 5 to 10%, often requiring surgical amputation later, and chronic fibrosis of the corporal bodies, which permanently destroys erectile function.
And what if we had to treat his groins? What happens to the legs?
Chronic, irreversible lymphedema is a major risk. By destroying the lymphatic filters, the fluid backs up into the legs and scrotum. It can be profoundly debilitating.
Given all these risks, our follow-up has to be rigid. How closely are we watching him?
Very strict. You must physically examine the primary site and palpate the groins every 3 months for 2 years, then every 6 months through year 5. For our CN1 patient, we also include cross-sectional imaging early and frequently because most regional recurrences happen within the first 24 months.
Okay, let's formalize the final case resolution for our 62-year-old anger patient. Let's synthesize the whole algorithm.
Let's lock it in. For his 2.5 centimeter CT2 primary, refer to a high-volume center for penile brachytherapy. Counsel heavily on the risk of late urethral stenosis, acute moist desquamation, and the requirement for pretreatment circumcision.
And if it fails, salvage partial penectomy as the backup.
Right. Now for his right groin with the mobile node, because he is CN1, we completely abandon the CN0 algorithm. no DSNB. We either get an image-guided biopsy or proceed straight to upfront bilateral ILND.
And if confirmed positive, bilateral ILND is the standard. If pathology shows extranodal extension, we discuss pelvic RT.
That is an airtight synthesis.
Great. To solidify these branching pathways, let's initiate a rapid-fire review of the most common ways residents fail this topic. Welcome to the board blitz and oral board traps.
I love this section. There are exactly 3 catastrophic traps you must avoid today.
Trap number 1. Misstaging the MRI findings and mixing the CN0 and CN positive pathways.
This is a huge mistake. If a biopsy shows lamina propria invasion, but MRI shows spongiosum invasion, it is a CT2. Do not call it T1B. Furthermore, the very moment you palpate a node, you are in a CN positive discussion. Do not let your brain drift back into sentinel node pathways.
Trap number 2. Suggesting a dynamic sentinel node biopsy for a palpable inguinal node.
We hammered this earlier, but it is an automatic failure. DSNB is strictly for clinically node-negative groins. The tracer bypasses a tumor-blocked node, giving a false negative.
Trap number 3. Speaking in absolutes during counseling, like claiming RT and surgery are perfectly equivalent or declaring adjuvant chemoradiation is strictly mandatory for all node-positive cases.
Use nuanced language. Say, surgery generally provides a somewhat more established local control, but RT is a highly reasonable alternative for organ preservation. Show the examiner you understand the nuance.
Excellent. Let's do 3 rapid-fire mini cases. Question 1. 55-year-old man. Punch biopsy of a 1.8 centimeter lesion shows well-differentiated squamous cell carcinoma invading the lamina propria. No LVI, no PNI. Bilateral groins are clinically negative. What do we do with the groins?
Staging. Lamina propria is T1. Well-differentiated with no LVI or PNI makes it a strict T1A. Exam is negative, so CN0. For low-risk T1A CN0, the risk of occult metastasis is very low. The correct answer is rigorous clinical surveillance. Do not offer prophylactic DSNB as a default here.
Spot on. Question 2. 67-year-old man, 3 centimeter, grade 3 SCC. MRI shows superficial corpus spongiosum invasion, but no cavernosal involvement. Groins are clinically negative. Can we do organ preservation, and what about the groins?
Spongiosum invasion is T2. It is under 4 centimeters, no cavernosal invasion. Definitive brachytherapy, or EBRT, is highly reasonable post-circumcision. Grade 3 doesn't disqualify him. However, for the groins, he is CN0 but has a high-risk T2 primary. Surveillance is unsafe. He requires invasive staging, preferably DSNB.
Perfect logic. Question 3. 58-year-old man. Post-partial penectomy and bilateral ILND. Margins negative. Right groin had 3 positive nodes with extranodal extension. Left groin negative. What is the mandatory next step?
3 positive nodes and ENE makes it PN3 disease. This is extremely high risk. Surveillance is malpractice. You must state this requires immediate multidisciplinary tumor board discussion for pelvic lymph node dissection and adjuvant radiation therapy.
The logic holds up every single time if you just follow the strict anatomical rules. We've covered the histological divide, staging, radiation techniques, and the profound human trade-offs of organ preservation.
It is a massive amount of intricate information. The overarching theme here is discipline. You cannot mix the primary T-stage lesson with the nodal pathway lesson.
And before we wrap up, I want to leave you with a final provocative thought. We talked heavily today about strict anatomy and nodal staging being the absolute unchanging law right now.
Right.
But think back to the deep histological divide we discussed at the very beginning, the HPV-associated versus HPV-independent pathways. Our 62-year-old anchor case was P16 positive.
Yeah, driven by the virus.
As molecular profiling evolves, consider how grouping all penile SCCs together might eventually fracture. We saw this exact paradigm shift rewrite the rules in oropharyngeal cancer, where HPV-driven tumors have their own de-escalation trials.
It is a totally valid comparison.
Will we eventually see a world where we can safely observe a CN0 T1B groin simply because it is P16 positive? Or where radiation doses can be safely lowered from 70 gray down to 60 gray to drastically reduce the risk of urethral stenosis?
The trials aren't there yet, but it is a fascinating space to watch over the next decade.
Complete practice oral boards at radongsmartlearn.com and subscribe to Radong Smart Review for our next episode. Thanks for tuning in.